Hello everybody, my name is Ahmed الصيرفي. I'm a professor of cardiology at Ain Shams University, and today we're going to discuss the guidelines for myocardial revascularization from a perspective of a case presentation and how to manage these cases. This is very important because this is the way we are going to manage our patients in later. This is according to the guidelines published in 2018 by the European Society of Cardiology and the European Cardiothoracic Society. And this is important because it takes into consideration every aspect of coronary vascular disease. And we should understand that it started in 1964 before it was the first CABG operation, and the first intervention by coronary intervention percutaneously was done in 77 by Andreas Grunzek. And there has been so many improvements and also better equipment used from the years later and later. So let's start with, at that time, stable angina, but of course you know now that is called chronic coronary syndromes. What do we do? This is a patient, he's 51, he's a smoker, hypertensive for the past 3 years, and complaining of shortness of breath on exertion for the past 3 weeks. His blood pressure is 150/90, his heart rate is 64, and his ECG and echocardiogram were normal. And this is a regular, very common case that you see in your everyday life. So what to do? Do we just jump into coronary angiography for this patient, or do we have to stratify the risk for this patient? Of course, there are so many things. There are so many columns and rows and ways to assess the patient, but the most important is assessing the chest pain and the age and gender. If you look at typical chest pain on the right hand side, which is chest pain that is retrosternal, going to the jaw or the left shoulder or right shoulder, and is increased by exertion or emotional stress and relieved by sublingual nitrates or arrest, this has the highest pre-test probability of coronary artery disease. In the middle, the atypical chest pain, it can be like the typical chest pain, but losing one of its characters, whether it is retrosternal in character, does it come with exertion or by emotions, and does it be relieved by sublingual nitrates or rest. If it has two of these three characters, it's called atypical. Non-anginal chest pain has one of the characters or none at all, and this could be due to many causes. And if we look at our male patient who's 51 and atypical because he had not chest pain and it was mainly shortness of breath, the pre-test probability is 65, so it's not very low. It's not very high, as 85 is extremely high, and then we need to go to a coronary angiography immediately, but it is not so low to say that this patient has none. And this is where non-invasive management comes. We can do in non-invasive management in so many cases, and there are so many modalities. But the preference now is not for the exercise ECG test, it's mainly for the stress echo, the nuclear imaging, the stress MRI, and the PET perfusion. Why? Because they are more accurate and more sensitive. So our patient who had a 65% likelihood of coronary artery disease, which we call now intermediate, what's below 15 is called low, what's above 85 is called high. This is intermediate, so here a class 1 is to do a stress echo. Look on the top right corner. If this patient has a very high probability of coronary artery disease, then we can go to an invasive coronary angiography from the start. This is really important. And if this patient is like ours, we should do a non-invasive test. So we did a stress ECG as part of the SPECT, and it showed ST depression, as you can see, mainly in the inferior and lateral leads, and it is rather significant because it's horizontal and it's more than 1 millimeter in these leads. And then we take a look at what we're going to do. Why are we doing angioplasty or coronary revascularization in chronic coronary syndromes? For 2 reasons. The second is symptoms. That is, if you have a significant coronary artery stenosis in the presence of limiting angina or exertional pains, or angina equivalent, like the shortness of breath our patient has, with insufficient response to optimal medical therapy. So symptomatically, yes, it's class 1A, but does it improve the outcome? Not in all cases. For improvement of outcomes or better prognosis, this is done when the patient has left main disease more than 50%, proximal LAD more than 50% because they have a huge amount of myocardial supply, 2 or 3 vessel disease with stenosis more than 50% and impaired ejection fraction because the patient has a low ejection fraction, any large ischemia by functional testing and more than 10% of the myocardium as defined by the COURAGE trial, that a defect more than 10% really improves outcomes if you have revascularized this patient, or an abnormal invasive FFR, or a single remaining patent coronary vessel with stenosis more than 50%. Here again, we are going to improve the outcome for the patient. So this is very important to take into consideration. Another small point you might not really look into so much is FFR cutoff point is 0.8. But if you have, or 0.75 again, sorry, 0.8 if you have a hemodynamically relevant lesion which is seen by non-invasive testing. So this is our patient. His left coronary angiogram shows a lesion, a very tight lesion in his circumflex or obtuse marginal branch, a borderline lesion in his LAD. I'm just giving you the snapshots seen in the lateral projection here, a borderline lesion in the LAD, a definitely significant lesion of the circumflex, and if it's more than 90%, you really don't require FFR. And another lesion in his right coronary, which is a little bit longer than the previous 2 lesions. So, what to do? We have 3 vessel disease. Do we just intervene without thinking? No. We should remember, maybe this is an easier case, but we should always think in multi-vessel disease and significant coronary artery disease of the heart team. The heart team constitutes of the interventional cardiologist, the cardiac surgeon, and the clinical cardiologist who assess the patient's different outcomes, different subset of diseases, different comorbidities. And it might be expanded if the patient is diabetic, if the patient has a problem with anesthesia, if he is COPD, and then you can add also a pneumologist. You can ask a geriatrician if the patient is extremely old, if he has CKD, a nephrologist. So the heart team is not just the interventional cardiologist and the cardiac surgeon, it might expand to a lot of different specialties. And when we discuss PCI versus CABG, we have to assess the surgical risk. A lot of us are a little bit well to do with the Euroscore 2, which is class 2B, but the most important to assess in hospital or 30-day mortality and in hospital mortality as a class 1 is the STS score. This is very important to assess the surgical risk if the patient is going to surgery. But further before that, we should also assess the complexity of the coronary arteries. Is it multivessel, bifurcation, if the patient is diabetic, left main? And this is very importantly done by a landmark trial called the syntax trial, and they showed us the syntax score. And this is also class 1. How do we do the syntax score? Very simply, first of all, it's dominance. It's all web-based, and you do not need to memorize numbers or anything. So we see the dominance. Is it right dominant or left dominant? Second of all, you look at the lesion, and you just pinpoint where the lesion is, and then there will be a calculator that will calculate the problem. Then you look at diameter stenosis. If the diameter stenosis is between 50 and 99, and 5 times in the case of occlusion if it's more than that. In the case of total occlusion, more questions will arise if it has been more than 3 months, which is the chronic total occlusion. If the stump is blunt, a little bit more difficult in crossing the lesion. Bridging collaterals, again, is a difficult problem that increases the complexity and favors a little bit bypass surgery. If the first segment is visible distally, or the side branch at the part of total occlusion, these will enhance or show the difficulty or possibility of success in PCI. Again, if the lesion is not just a bifurcation or a trifurcation, these increase according to the number of disease segments that are affected. So again, it is simple to use, but very illustrative. Bifurcation lesions, again, how is the bifurcation? Is it a Medina 1, 0, 0, a 0, 1, 0, a 1, 1, 0? This is a +1, not so difficult. But if it's a triple 1, this is more difficult. So this is really important. And if the bifurcation angle is less than 70 degrees, again, an additional point is put there because it is more complex to intervene upon. If the patient has an aortic osteolesion, more common in the right coronary, again, this adds another point. If there is severe tortuosity, if the lesion length, according to the SCI and the American Heart Association, which says that more than 20 millimeters is a long lesion, then another point can be added. If there is calcium, thrombus, or diffuse disease, again, this is important to take into consideration. You shouldn't memorize them because if you go into the algorithm inside the internet, it will go through every part of this and it will not be completely accurate. So we did this for our patient. We did a syntax score and it showed us a syntax score of 10. What is 10? Is it high? Is it low? Is it not? As you can see, of course, first of all, it shows us that CABG and PCI, and of course the original syntax with the taxes, the paclitaxel eluting stent, there is no major difference in the cumulative event rate over a period of nearly 4 years. Okay? If we have a low syntax score, then PCI and CABG are very equal in pre-vessel disease. If you have an intermediate or a high syntax score, no, CABG is much better because the recurrence of myocardial infarction, the target lesion revascularization or target vessel revascularization is less in CABG than in PCI. So here, CABG is better if you have an intermediate or high syntax score when we are talking about multi-vessel disease, like our patient. If we have left main, this is a different entity. So here, let's take a look. If we have a 3-vessel disease or left main disease, then we took the syntax score into consideration. In left main, let's start with that. If the syntax score is between 0 and 32, PCI can be done. CABG is always class 1A, but PCI can be done. If syntax score in left main is above 32, then CABG is definitely much better and PCI is not indicated. How about 3-vessel disease? We looked at the syntax score. If it's very low, 0 to 22, we look at the diabetes. If there is diabetes, always CABG is better, but PCI can be done. If it's not diabetic, then both are equal actually for target lesion revascularization, myocardial infarction, and target vessel failure. But if the syntax score is not above 32, it's above 22 in 3-vessel disease, regardless diabetic or non-diabetic, here CABG is better than PCI. So here is our patient. Actually, he's non-diabetic. His syntax score was 10, and he has possibility to do PCI or CABG. But how to choose? Well, there are so many things. There are things that favor PCI. A lot of patients prefer the PCI instead of the sternotomy, of course. But there are things that prefer CABG, like diabetes, reduced left ventricular function, especially if it's in heart failure, or if this is a recurrent diffuse instant restenosis of the patient cannot continue endure antiplatelet therapy. PCI is preferred if the patient has severe comorbidities and anesthesia is going to be difficult. If he has advanced age, is frail, is reduced life expectancy, has a terminal illness and might die very soon, or he has restricted mobility. So again, it's not only the syntax, it's the syntax too and the clinical symptoms that the patient has. And of course, when we compare PCI with drug-eluting stents, we should take into consideration that CABG should be done also according to the guidelines. And this includes minimizing aortic manipulation, off-pump if the aorta is calcified or if high risk, complete revascularization, not just a couple of grafts. Endoscopic harvesting is really important and no-touch vein harvesting. And if you have high-grade stenosis, a radial artery is preferred. So if you are talking about arterial total revascularization, CABG always wins. But if this is not going to be done, then this is subsuperior CABG. This is not going to be compared to PCI in certain indications. And why is this? If CABG is done according to the guidelines in multivessel disease and in high-grade syntax score left main disease, there is an improvement of outcomes with CABG, which is significant. This is really important. But if you have not so complex disease, whether in left main or in multivessel disease below 22, then PCI can be comparable to CABG. But if diabetes is put into the equation, diabetes increases a lot the side effects in multivessel disease. Not in left main, there is no difference in left main if the patient is diabetic or not so much, I'm going to say, but statistically significant, of course, if the patient has multivessel.